This podcast is for healthcare professionals only, and AstraZeneca has provided a sponsorship grant towards this independent program.
Hello, and welcome back to the Oncology Brothers podcast. I'm Rohit Gosain. I'm here with my brother and co-host Rahul Gosain. Today, we are wrapping up our 4-part series on hepatocellular carcinoma, with a focus today on intermediate hepatocellular carcinoma with evolving role of immunotherapy and stressing the importance of multimodality approach. Prior to this, in the past 3 episodes, we have focused on advanced disease and treatment in frontline and on progression. And we've also covered intermediate HCC from staging standpoint. With that theme in mind, I'm joined by Dr. Nina Sanford, a radiation oncologist from UT Southwestern, Dr. Edward Kim, an interventional radiologist from Mount Sinai, New York, and Dr. Mark Yarchoan, a medical oncologist from Johns Hopkins. Nina, Ed, Mark, welcome.
Mark, can we start off here with a brief overview of intermediate HCC and broadly the current treatment landscape? We have covered this a little more in depth in our 3rd episode, but if you can lay some foundation down.
Absolutely. So, intermediate stage HCC is a bit of a historical term. It was really defined in an era when we didn't have effective therapies for HCC. And at a very high level, it refers to patients who have HCC that is confined to the liver. And these patients, at least in theory, may be candidates for some sort of loco-regional approach to their therapy that generally can only be offered to patients with liver-confined HCC. I think in a contemporary era, we're increasingly recognizing that this is a super heterogeneous group of patients. They're patients who really have, a systemic process here, where the scans may only show lesions in the liver, but really, even though there's a propensity for liver metastasis, this is a systemic process, and these patients tend to have more disease and be better candidates for systemic therapy. I think on the other end of the spectrum, there's a group of patients with intermediate stage disease where the goal is really to cure them through downstaging and transplant. And then somewhere in the middle, there's a group of patients who have, I think, even though they have multiple lesions in the liver, this is more of a local process than a systemic process. And at least initially, the goal is loco-regional therapy.
Thanks for laying that foundation, where local regional therapies are extremely important. As a result, the need for multimodality approach is so important here. Now we have the combinations of IO with local regional therapies, and this need only gets more important. Nina, first, we need more representation of radiation oncology for BCLC to have a truly multidisciplinary approach. Now, diving into the topic here, can you please touch on some of the modalities available for radiation oncology in this space, please?
So I think I completely agree with Mark with regards to defining intermediate risk and how historically it's sort of fallen into 3 buckets, sort of downstaging for transplant, more the systemic with greater disease burden, and then sort of in the middle, this sort of destination local therapy. I think the lines are blurring between the 3, though, with hence the need for combination therapies. But I think radiation has a role in all those sort of 3 frames. If we think downstaging to transplant, then radiation could be used as either bridge or downstaging, in this case for intermediate risk, if they're initially above the Milan criteria, both in UNOS downstaging. If we think of destination local therapy, historically it's been TACE and now TARE. I think radiation has a role as well in for more well-defined isolated tumors that are intermediate stage. And then the last is historically patients who have been treated with systemic therapy. We think of that really for patients with like greater than 50% liver involvement. I think Dr. Kim may talk about combination TACE and immunotherapy studies, but there is emerging data on the combination of radiation and systemic therapy as well. I'd just like to quickly highlight 2 studies with that regard, because there's not a lot of data for radiation in this setting, but one is RTOG 1112. This is non-immunotherapy, it was sorafenib, like a lot of the studies started earlier, used sorafenib instead of more current treatment regimens. But this was a study randomizing patients with intermediate stage B or stage C HCC, though the majority were stage C. They were randomized to sorafenib with or without SBRT. And the study found that the addition of SBRT improved PFS from about 5 to 9 months, but also improved OS from 12 to 15 months. So I think, of course, the major caveat is that sorafenib is the comparison arm, but I think those data are compelling to take it sort of to the next trial with immunotherapy. Also, a smaller retrospective study that was recently published in JAMA Oncology. This was a study looking at combination of immunotherapy and SBRT in all patients, though about 2/3 of them, or 3/4, also got TACE as well. And complete response rates for these pretty extensive tumors, I think the median size was like 10 centimeters. The majority had vascular invasion, was actually close to 50%. And I think that is compelling data, but still, single institution, non-randomized. So I think going forward, we need more randomized data looking at radiation.
That's great. Thanks for touching on this, because as a community oncologist, it is so important for me to partner up with my neighboring radiation oncologist. And let's pass the baton on to interventional radiologist here. Ed, as an interventional radiologist, what are your thoughts on the data that we have in hand, be it for EMERALD-1, where we have durvalumab with or without bevacizumab with TACE, and LEAP-012 with pembrolizumab and lenvatinib with TACE? Your thoughts around this and TACE versus TARE?
I think that both of those trials were read out as positive, with the primary endpoint being progression-free survival, and they're roughly similar, about 15 months. The difference, I think, in trial design between the two is that EMERALD-1 was really successive therapies. You do the TACE first, and then you add really the bevacizumab. You start with the durva, and that showed a benefit in terms of the primary endpoint. And then LEAP-012 was concurrent therapy, so really started at the same time with their regimen. And so you have kind of the same types of outcomes. You do a subset analysis, higher disease burden, whether it's up to beyond 7 or beyond 6, all seem to benefit because you have multifocality of disease where transarterial therapies seem to derive a benefit. We have to see, right? Because in light of IMbrave050, where everyone was very excited about a positive primary endpoint of PFS, ultimately, the median OS showed no benefit, and everything else actually was statistically insignificant. And I think we have to really focus on these studies and look at the overarching theme. There may be trends that we see, but ultimately, if it's statistically insignificant and it's a negative endpoint, is there a benefit? And I think we have to really, I think most people are kind of a wait and see approach with both EMERALD-1 and LEAP-012, looking at how is the median OS going to read out. Not to mention the heterogeneity of the intermediate stage. If we're using, let's say, the Barcelona criteria, touching on the different therapies, I think downstaging, we know with established evidence, multi-center prospective phase 2 type studies, that radioembolization really achieves that quicker and has a sustained response with a duration of response that's quite long, up to 2 years with our study, the RAZOR study. And so that is I think, different type of goal and patient population as opposed to the, let's say, infiltrated. We have high alpha fetoprotein and aggressive tumor biology, where I think it's well established that we go to systemic in those individuals. Now, does LEAP-012 and EMERALD-1 bring into that type of patient population a transarterial-based therapy? It's yet to be seen. I think that is why there's importance of multidisciplinary teams. And then, as Mark had mentioned, the multifocal disease without too much disease burden, whether you go by the Belandi or Kinky criteria, everyone has their own criteria, Japanese TACE criteria, et cetera. We're really looking at lower tumor burden, but in actuality, we're trying to discern which patients may be having a less aggressive tumor biology that is contained within the liver, that is not potentially going extrahepatic, et cetera, with an aggressive tumor biology. And so I think that is a crude measure based on tumor burden, how many nodules there are, in terms of lower kind of aggressive tumor biology, well-differentiated HCC that could potentially derive a benefit from loco-regional therapy alone, TACE or TARE, et cetera. And then holding off on systemic therapy, because I'm sure we can get into this discussion as well, but how does combining therapy earlier on in the intermediate stage affect the data that we have with Himalaya, with IMbrave 150, with Nivo-IPI in the advanced stage? And so I think that is what people are trying to kind of elucidate right now.
Wanted to quickly, give my thoughts on Emerald 1 and LEAP. I think this goes back to what Mark had mentioned. To me, they're really trials of whether or not to give immunotherapy upfront or later, right? Like Mark mentioned, a lot of these patients are going to need systemic therapy later because unfortunately they're going to have progression. The criteria for LEAP, this is incurable cancer. That's literally on the slide. So I think to call these trials positive, they really need to show an overall survival benefit. They're positive because the primary endpoint is PFS, but in terms of impacting patient care, we really need to show an overall survival benefit. In LEAP 12, the incidence of grade 3 to 5 adverse events was 70% for patients in the combination arm, more than double with the TACE-only arm. So it's a very costly drug, and you don't show a survival benefit. If you look at the curves that have been presented, I cannot imagine that long-term you're going to see a survival difference if you look at the curves presented thus far. Finally, I think there is some data showing correlation between PFS and overall survival for advanced HCC, but that has not been shown to my knowledge for intermediate stage HCC.
Mark, I'm sure you got some interesting thoughts from a medical oncology standpoint, because again, we have been relying on the PFS quite a bit, and that has been the debate. A lot of trials, especially when the readout for overall survival is way down the road, how do you interpret the PFS aspect to it? But at least for HCC, things are sort of moving fast. So yes, I'd like to get your thoughts here.
I don't disagree with anything that's been said. And I might say the same thing, but with a slightly different take in the end. I think there's been this natural creep of systemic therapy earlier and earlier in the treatment of HCC. And just for some historical context, when I was first treating this disease, a lot of patients would get repeated TACE or TARE or other loco-regional procedures to the liver, and eventually they would either run out of liver reserve because of repeated loco-regional procedures, or would just develop a loss of tumor control. And by the time that they would come to see me in medical oncology, essentially I would be having a hospice discussion with them. And that was actually okay, because it wasn't like these patients were missing the opportunity for a great systemic therapy. We didn't have much to offer them. I think in the contemporary era, where we have much better systemic therapy, what we really don't want is for patients to truly miss the opportunity to go on potentially multiple lines of systemic therapy. So I think there is some natural creep as we get better systemic therapies. We want to move them earlier. And there is retrospective data, at least with a propensity matching study, that for patients with larger tumor burden, so beyond up to 7 criteria, the sum of the diameter of the lesions, they may do better with upfront systemic therapy than TACE, at least. And that benefit, that overall survival benefit, retrospectively, is actually driven by preservation of liver function. When we look at the LEAP data and the Emerald 1 data, it's very early data. I personally don't think that at this point it's truly practice changing. All we know is that the scans look prettier when you combine both modalities versus one modality. But I do think that it sort of supports the general natural trend that's been happening anyway, that systemic therapy has moved earlier. And really, the hope is that if we can move systemic therapy earlier, number one, we don't miss opportunities for patients to get systemic control. But number two, we can really focus loco-regional therapy on treating oligoprogression or residual lesions or debulking in the setting of systemic control, rather than just using systemic therapy as a last result. So Again, I think we need longer-term overall survival data. The LEAP study, at least overall survival is trending in the right direction, but certainly not at the point of statistical significance right now. So I think these data are eagerly awaited. I do think it will be very helpful to also have studies of systemic versus TACE in the intermediate stage, and like the REPLACE study and the ABC study, because right now it's all about combination, and the sequencing is still a real question.
Mark, can I push you a little further on the LEAP and Enrolled-1 data? Based on PFS, while we're waiting on OS, have you adopted this already in your clinical practice outside clinical trials?
Well, it's a very straightforward question, but I'm going to give you a sort of roundabout answer. I think my suspicion is everybody on this call has been combining systemic therapy and local therapy in the intermediate stage for much before these studies were ever published. In fact, every single major first-line systemic therapy study includes intermediate patients, and there's a survival benefit to systemic therapy in that setting. So I think some of this was happening naturally. I haven't done it more since these studies came out because I think that the data is very preliminary, and I think, I still think at this point these patients really should have multidisciplinary input, come through an MDC, and there is really a lot of value to institutional experience right now because I think the clinical data are still very challenging to interpret in these large studies.
Mark, how does the tumor board conversation look like in your space? Or what is rather an ideal patient where you will reutilize this approach? And then we'll ask Nina and Ed on how their multidisciplinary approach works, where medical oncologists have added some of the systemic therapy in upfront settings, and you've rather seen some responsiveness here.
Yeah, I think it's hard to sum up, everything that we do in just a quick soundbite here. But, I think that there are patients who benefit from systemic therapy. These are patients with larger tumor burdens, infiltrative disease, patients where there really is a good shot of downstaging, and systemic therapy can help achieve that goal. I also think there are patients who benefit from loco-regional therapy, and Ed and Nina can better define who those patients are. And so, in my mind, patients come through the MDC, and we go through two separate algorithms, and there are patients who may benefit from both. And until we have longer-term follow-up, I think it's a case-by-case situation where we really think about these patients holistically.
Ed, what is this conversation on your end at the tumor board?
I think the multidisciplinary tumor board, and we have also multidisciplinary office hours in conjunction with our transplant and our medical oncologists are across the street, I think is essential to taking care of HCC patients. As Mark was talking about previously, we know that back when we had no options other than sorafenib, which was quite poor with a 2.7-month median OS benefit with the SHARP trial, it's not much. I would be at tumor boards where I'd say, all right, I don't think we can do any further loco-regional therapy for this, or it's not a great candidate. And my colleagues would say, we have no other option, and kind of push us to do it. I think we are still undergoing a cultural shift now because the positive trials with systemic therapy are coming fast and furious, like literally every year. And so it's quite exciting, but I don't know if the medical community as a whole has caught up. And so we have to change that cultural mindset, for instance, where interventional radiologists are continuing potentially to do transarterial-based or loco-regional therapies over and over and over again to the detriment of underlying liver function. And so I think we need to educate better in our tumor board. If I feel that we've exhausted loco-regional therapy in the sense that the patient is still has good underlying liver function, I will say, listen, why don't we hand off this patient? I'll give an example. We do let's say a Y90 for a patient, and on follow-up, there are multiple new lesions that pop up. Could I go after those lesions? I could, but there's probably something else going on. And we'll hand off to systemic therapy and say, hey, is there anything you guys can do? And say, okay, let's trial this. And if they progress after this and there's still Child-Pugh A ECOG performance of 0, then, okay, let's revisit loco-regional therapy. But they may be part of that 33% that has an objective response rate to the checkpoint inhibitor, really. If they do, it's fantastic. We know that they have a meaningful median OS benefit. Now, 17, 19 months for the advanced stage. So, this is a very complex decision-making and discussion, but essential to take care of HCC patients.
Nina, anything to add here from multi-D tumor board discussion?
Yeah, I completely agree. I mean, I think there have been so many times where because HCC, there's so many treatment modalities, so many local treatment modalities, you think that one makes sense. And then someone says something, you're like, oh my God, I didn't even think of that. But that's probably a better option. And I think for, those of us who are focused on the local treatments, it's really important to know the other local treatments. Like I've recently spent a lot of time learning the IR literature, learning the surgery literature to really see, in a patient who could potentially qualify for several, what is the best one. I think the potential of transplant is what really complicates things and can sometimes complicate the decision for local therapy, because a lot of times you're thinking, well, maybe I wouldn't give this patient local therapy, but that might be their only route to potentially qualify for transplant that could potentially compromise liver function. But, should you really, give them that last opportunity to potentially receive curative treatment? So I think that is definitely a scenario that especially needs multidisciplinary discussion. But otherwise, I totally agree with what everyone else said.
One more point. I mean, Ed spoke a lot about the sort of earlier handoffs to medical oncology, but I think it's important to emphasize bidirectional handoffs because, we're not curing that many people with systemic therapy. There are the occasional CRs, but, I think we get a long period in some patients of excellent disease control and good tolerability of therapy and preservation of liver function. Eventually, in most cases, there's progression. Often that progression happens not uniformly, but often in the liver, which is a more immune tolerant organ. And so more and more, I think we need to adopt a culture where patients can go back to loco-regional therapy. It's a much more back and forth. And so, at least at the institution where I practice, we have shared office hours, a shared clinic, and it's very common for patients to come through that clinic not just once, but repeatedly at multiple stages of their care. So I just want to emphasize, I don't think loco-regional therapy is going away. I think that sequencing is changing.
Before we close, I'll take some clinical takeaways from discussion and any final thoughts for our listeners on intermediate HCC.
So one thing I didn't mention, I just wanted to put a plug in for an upcoming trial, probably opening next year through NRG Oncology, one of the cooperative groups. So this is a trial looking at, as we mentioned, immunotherapy plus or minus SBRT. So this is a randomized trial of atezo-bev or STRIDE plus minus SBRT. Right now, it's just for Barcelona class stage C. So, the more advanced than what we had talked about, given current standards of care. But I would predict if new data comes out, they may also include some stage B. So definitely keep an eye out for that study. I think it's, what would really help provide data for radiation in this setting. And I encourage folks to enroll. Thanks.
Mark, your final thoughts and key takeaways?
It's a great time to be a medical oncologist because we actually have things we can do that meaningfully help patients with HCC. I think we have some intriguing early data about combination therapy that fits with a broader trend, but longer term follow-up is clearly needed.
Ed, your key takeaways from today?
It's essential to work within a multidisciplinary team for just multiple levels, patient care, the whole aspect of patients potentially going to a curative transplant. And again, working with our medical oncology colleagues to hand off patients and as Mark had mentioned, to receive patients back. We've had patients that have gone on several years off of checkpoint inhibitors, but checkpoint inhibitors what initially got them there, and then they have breakthrough progression, and we can perform loco-regional therapy and still keep them, maintain their performance status and their underlying liver function. And also, we're investigating all these combination therapies, whether in the intermediate stage or advanced. I mean, the Rowan trial is a phase 2 study combining radioembolization and Durva and Bev, and then there's the Emerald Y90 that's combining radioembolization plus Durva and Tremi. So I think it's an exciting time. There are a lot of options for patients.
So there are multiple exciting trials that are taking place. Only time will tell how the overall survival data plays out. Nina, Mark, Ed, thanks so much for your valuable insights. Multidisciplinary approach is an extremely important aspect of medical management, especially when it comes to HCC. And these conversations continue to reiterate that. Thanks for joining us. For our listeners, let us go over a quick recap. Intermediate HCC is a heterogeneous group requiring multidisciplinary approach. Today, with Drs Nina Sanford, Ed Kim, and Mark Yarchoan, we had a chance to discuss more of liver-directed therapies along with immunotherapy. As we continue to see the data in this space with multiple combining regimens, that is, durvalumab with bevacizumab or pembrolizumab with lenvatinib, only time will tell how this all plays out.
This discussion concludes our 4-part series on HCC. We had a chance to cover available treatment options for intermediate and advanced metastatic hepatocellular carcinoma. Make sure to check out our other 3 discussions in this series. Thank you for joining us. We are the Oncology Brothers.
If you enjoyed this podcast and want to find out more, then please look for the Oncology Medical Conversation podcast under the account of Core2Ed Medical Education. Also, don't forget to rate this podcast, subscribe to our channel, and share it with your colleagues. Thank you for listening and see you next time. This podcast is an initiative of Core2Ed and developed by HCC Connect, a group of international experts working in the field of oncology. The views expressed are the personal opinions of the experts, and they do not necessarily represent the views of the experts' organizations or the rest of the HCC Connect group. For expert disclosures on any conflict of interest, please visit the Core2Ed website.